Now I'll give it a shot. My name's Graham Sacrison. I'm the president of North Thurston Public Schools School Board. And I want to really express my pleasure and enjoyment in seeing you here this evening. Community engagement is one of the major principles by which our board operates, to try and stay in touch, listen to what people have to say, inform ourselves so that we can make good decisions. So this evening is an opportunity for us to hear from professionals in the area and also to hear from you on what your ideas are, what your thoughts, what your concerns are. So this is a very collaborative effort this evening. This evening we are talking about responsible, resilient, and empowered learners. Now, we have it posted up there, but I think I'll read it because, at least with my eyesight, that's not so readable. But we say every student will feel safe as an empowered, responsible, and resilient learner, open to and accepting cultural diversity and perspectives, and empowered to advocate for and pursue their own educational passions. There are several outcomes we're looking at. One, first A, increased percentage of students meeting social, emotional, and behavioral expectations. B, an increased percentage of regular school attenders. Being there is crucial. C, increased opportunities for student voice, and this is an area where the district has really, I think, stepped up and brought students together to advise and to participate. And an increased percentage of students open to and accepting cultural diversity. So these are all critical parts that we see of the educational experience. I'm not going to go on and on. I am now going to introduce Mel Hartley, who is going to then facilitate the discussion with the panel. Thank you very much.
Hi, welcome, and thank you all for being here. Within the district, we've done a lot of exciting stuff lately. There are a lot of services that Leslie's going to tell you about. We did Breaking Down the Walls in the high school, which was sort of a lock-in to help kids build relationships. And so what we're doing now is I'm going to introduce the panel members, tell you a little bit about them, and then I'll ask them some questions to answer. Because mental health care services are sometimes hard to find, and that's part of the reason we brought the folks to you tonight, to be able to tell you about all the great services that are in the community. So first, I have Gilberto Maldonado. He's a program manager at CMAR Behavioral Health. He began his career at CMAR in 2015 at the Tacoma Adult Treatment Center. He completed his undergraduate work in social sciences while serving in the Army, and he got his Master's of Social Work degree from University of Louisville, Kentucky. He's an advocate for veterans, families, and other underserved populations. So, Mr. Maldonado, welcome. Next, we have Alicia Faris. She's the Chief Clinical Officer for Community Youth Services, often referred to as CYS. It's a nonprofit based out of Olympia, serving adolescents and young adults. And I'm sure on your drive downtown from Lacey, you've seen their brightly colored building. She works with broad and integrated continuing care. She has her master's in counseling psychology from the Alaska Pacific University. She has experience in juvenile justice, community health clinics, schools, tribal centers, and homeless drop-in centers. She works with universities, state agencies, and the legislature to meet the unique needs of youth in our state. So welcome. Shelly Willis is the Executive Director of Family Education Support Services. She has over 25 years experience as a mental health advocate, educator, and advisor. She's also a proud graduate of North Thurston Public Schools. In 1998, she began her nonprofit career with BHR. She supported Child Care Action Council, Family Support Center, and Community Action Council, and then in 2000 launched Family Education and Support Services. They serve over 7,000 individuals annually, and they ensure healthy development of kids through evidence-based family strengthening services. Thank you for being here tonight, Shelly. Jessica Shook is the Clinical Manager of Olympia Health and Recovery Services, OHRS. She's a licensed mental health counselor and a designated crisis responder. She does involuntary treatment assessments, and OHRS holds 7 counties to include Thurston and Mason counties. Her undergraduate degree is in psychology from University of Washington, and her master's of counseling in psychology she received from the University of Denver. So welcome. Thank you for being here tonight. Eliza Smith is a supervisor for crisis services at Providence St. Peter Hospital. She has experience with mental health and social services, both here and abroad. She has a master's in counseling, and she does inpatient adolescent unit experiences, and she helped and was on the first mobile outreach team in Pierce County, as was Jessica, I just learned. So thank you, Eliza. Thank you for being here. They've served over 7,000 individuals in the last year. Then we have our very own Leslie Van Leeshout from North Thurston Public Schools. She's a director of student support. She has 30 years from preschool to higher education. She has her master's in educational leadership from Seattle Pacific University, and she oversees the mental health, counseling, and health services for all of the students. She does phenomenal things with the homeless students backpack program and support. And she is a Golden Apple Award winner and a published author. And we thank you for being on our panel tonight, Leslie. Now we will start with the questions. Okay, we're going to start on different ends. I'll start with Mr. Maldonado first. Can you tell, and again, Ms. Remy Anderson is going to be our timekeeper, so we'll keep everybody shortly on time. Speaking of time, I apologize tonight. You will see me sneak out later. School board takes first priority except when it is senior night for the soccer team, and my daughter's the captain and a senior. So I must sneak out of here, and I apologize. All right, you ready for your first question? We're ready. Okay. How has your organization supported emotional and behavioral health of youth?
Good evening, everyone. CMAR Behavioral Health Centers, we provide emotional and behavioral health of youth by providing mental health assessments, individual therapy. We also provide group therapy. We have psychiatric services that include psychiatric med management. We provide case management that includes advocacy for the students. We do limited school-based services in the Tumwater School District where we are located. We also have initiated a collaborative care model that has allowed us to place mental health professionals at our primary care clinics that will help youth and their families navigate and locate mental health and behavioral health services. That's what we do.
All right. Thank you. Same question, Ms. Faris?
Sure. So Community Youth Services has been around for almost 50 years now, and about 6 years ago, they wanted to add behavioral health to the continuum of care there, and that continuum is everything from therapeutic foster care to crisis residential centers, young adult housing, juvenile diversion. So we've got quite a broad spectrum, but what was missing in all of those services was tending to the emotional and behavioral needs of those youth. And it was recognized that if we're not doing real whole person care, it's difficult to sustain those outcomes in any of the other services we were providing. So we brought on services specifically geared towards transitional age youth, so adolescents and young adults, helping them to stabilize in their home and community, as well as build skills to be able to make that transition to adulthood, and provide support to families to be able to help those youth with the same things. We focus on trauma-informed care, recognizing that these issues are complex and they're never just as simple as a therapy session working with the symptoms that youth may be presenting. So we really stay focused on strength-based care and also helping them to build up those protective factors that will help them to bounce when things aren't going well in their life.
Thank you. Ms. Willis, same question. How has your organization supported emotional and behavioral health of youth?
Thank you. Family Education and Support Services has a mission to ensure children thrive to their greatest potential. And we do that. Can you hear me now? Yeah, I won't sing. We do that by ensuring that those who influence the adults, caregivers, teachers, anybody who influences kids have everything they need to ensure that child thrives. So we do that through 3 primary strategies. The first, intervention-based. We have a home visitation program called PCAP. It's for parents moms actually, who are addicted and pregnant. We stick with them for 3 years to make sure babies have the best start possible. We have classes, we go into the jail, provide parenting in the jail, and we go into treatment programs and provide parenting there as well. Partner with many community partners like BHR, CMAR, Community Action to ensure those most vulnerable families have everything they need to raise healthy kids. We provide classes when families reach trauma, like there's a divorce or domestic violence or poverty is impacting them in a negative way. We do everything we can to help that family stabilize and find the resources they need in the community. We have prevention-based programs where we partner with schools like North Thurston and provide free parenting classes to help parents gain the skills, resources, and collaboration, informal social arrangements they need to help continue to raise healthy kids. And we know that in Washington State, over 53,000 kids are living with a relative caregiver. And for every 1 child placed into foster care, there are 10 that go live with a grandparent or an aunt or uncle. And kids don't go live with their grandparent because things were going well. There's usually some trauma behind that. So we do our best to help both relative and foster parents navigate through that trauma, find resilience, and continue on raising healthy kids. We're not question 2 yet. We do a lot of community building as well. We have collaborations where we talk about the period of purple crying and how to handle babies who are crying and you don't know what else to do, and it's very stressful for everybody involved, and help navigate through that. Addressing depression and bullying. We have a bullying collaboration we're doing with North Thurston, and how do you address bullying in the community on November 6th at Chinook Middle School. And then we're providing free parenting for the community with the same speaker called Parenting with Wit and Wisdom. So we do everything we can to collaborate with community partners to make sure the adults who influence kids have everything they need to do the best they can.
Excellent. Thank you. Ms. Shook, same question. How has your organization supported emotional and behavioral health of youth?
So my agency, Olympic Health and Recovery Services, is fairly new. We've been around since February of this year, and we are the sole provider for involuntary treatment assessment in Thurston County for adults and for minors aged 13 to 17. So we are the professionals who come and do the assessment to determine whether or not a youth requires involuntary hospitalization. We also partner with Catholic Community Services to provide some crisis outreach in the community. One of our main goals since our agency started was to improve our ability to assist youth who are in behavioral health crisis. And we have been working on 3 things to further that goal. Our first task was to increase our outreach into the community, to go out to schools, homes, wherever the crisis is occurring. We want to avoid having youth go to the emergency room of a hospital unless it's absolutely necessary for safety. It can be a traumatic place. It can be a place where youth can have unsafe behaviors reinforced, and it often exacerbates the crisis. So our goal is to get crisis resolution and safety assessments back out into the community where they're happening. My second task was to improve my team's skills in working with youth. So to that end, I have specifically hired professionals who are children's mental health experts, who have experience in doing crisis planning and working with not only the youth, but also with their family. And our third task was to really emphasize outreach and collaboration with the other providers who work with youth, many of whom are on this panel. So that's what we've been doing.
Excellent, thank you. Ms. Smith, same question. How has your organization supported emotional and behavioral health for youth?
So in addition to having psychiatric emergency services in the actual emergency room, we also have outpatient chemical dependency services. So we really try and focus on both mental health and substance use, because we understand it can be and often is co-occurring. And so to do that, we look at exploring the mental, social, spiritual, cultural factors that can exacerbate both substance use and mental health in an individual. And then we try to create coping skills. We really do what a lot of the panelists have talked about as far as strength-based. In our chemical dependency services, we have an option to do intensive outpatient services, as well as outpatient services and education for youth. And we focus on a model called the 7 Challenges. And that program really emphasizes and facilitates self-empowerment. With our crisis services department, or psychiatric emergency department, we are able to do crisis mental health assessments, and those are done by master level clinicians. And then we use community collaboration as often as we can. And that lately has been with the mental health specialist team with North Thurston School District. We often have them come to our staff meetings, as well as additional community partners addressing community issues. 13 Reasons Why was something that we are involved in. We work closely with all of the programs here on the panel to do what we can to make appropriate referrals.
Excellent, thank you. And our very own Miss Leslie, tell us what all you're doing to support emotional and behavioral health of youth.
Not me, but the North Thurston Public Schools has a wealth of multi-tiered system of support that align with our strategic plan in the district. From everything from every school having a positive behavior intervention and support framework, which states specific expectations for students that are taught to students and reviewed regularly with a token economy to reward. 2, we have reached out to the community. We have many alliances from many of the people here on the panel, but also Treehouse for Foster Care. We have at CYS we have many different students who are part of that. We have worked with the ESD and True North to have assistants that are in each high school to help with any chemical dependency issues. But probably our crown jewel is that we have employed master level clinicians in mental health in our school district, which is very unique. And they are working with students every day. They do crisis services. They meet in therapeutic groups and individual students. They refer out to the community, kids with the most need, and they work with nurses, counselors, our PBIS coordinators, and all of the many other people who work with students. And so this creates a real tiered response to what kids need. all kids need something. Some kids need a little bit more, and then there are kids at the top that need even more individual services, and it's really wonderful that we're able to do that.
Thank you. Okay, now I'm going to switch it up a little bit, and we're going to start in the middle. Ms. Willis, can you tell me what are some of the challenges or opportunities for emotional and behavioral health of youth?
Our community has had some challenges lately. This year we've had a tripling of suicides and homicides, and that has impacted our children and youth and the homes that they grow in. Resiliency can make a difference, hope can make a difference, and I think there's some exciting things happening in our community to address some of those issues. I agree with Leslie, there's some phenomenal mental health workers here at North Thurston School District, and they're very busy and we need more. They need more. You're welcome, Teresa. I also think there's a great collaboration called ICM, Integrated Case Management, and I know that those folks are also in this room, and that is a collective multidisciplinary team of folks who get together and talk about how to best serve some of the kids who seem to be falling through the cracks. But that's 4 kids a month, and there's a need for more. We certainly see a challenge with self-regulation, kids not meeting their emotional level quite yet, and looking for services in the community, and there's not a lot for kids who are 6, 7, and 8. That age range seems to be missing. Kids impacted by complex trauma, not simple trauma, but complex trauma, and addressing those issues seem to come up over and over again. There's so much. Anxiety, depression, emotional regulation would probably be top 3 that we see over and over again.
Thank you. Ms. Faris, same question. What are the challenges or opportunities for emotional and behavioral health of youth?
What we're finding is that the opportunities, there's a ton of opportunities, and there are also challenges in and of themselves. One of those is the move of the whole medical field and behavioral health field to whole person care and value-based care. And that's some really exciting movement. So at CYS, we've integrated behavioral health, so mental health and substance use services, so that youth only have to go see one counselor instead of going to different clinics and a bunch of different appointments. But operationally, logistically, those are challenging to implement. Another opportunity is the state's dedication to evidence-based practices and increasing those in behavioral health providers across the state. Also logistically challenging to implement, but producing phenomenal outcomes. Same thing along the lines with the Medicaid transformation project in this state, integrating physical health with behavioral health. Operationally and logistically challenging, but a great opportunity to really meet all of the needs of the youth and their families in one place with one relationship with a provider, and making sure that some of their needs aren't falling through the cracks there.
Great, thank you. Mr. Maldonado, same question. Challenges or opportunities?
Well, I want to take a moment and talk a little bit about the challenges and also some opportunities that we've identified. And I want to talk specifically about the population that we serve in Thurston County. Certainly, you know, the change in the transformation in the insurance coverage and how people get served and where they can get served are unique challenges. I think more local. I've had the opportunity to meet with some of our child mental health specialists, and we had a roundtable. And we talked a little bit about complex psychosocial factors and how that impacts the ability of a youth to be able to obtain the behavioral health services that they need. A lot of our kids, they come from the foster care system, from multiple foster homes, where we're not always able to communicate and collaborate with the previous foster parent, and there's a lot of information that gets missed. There's a lot of complex trauma. There is unstable homes, and oftentimes there's a lot of substance abuse involved that creates barriers for the child to obtain the services that they need. We also identify technology as a potential challenge, and the information that is being communicated to the youth, information that is perhaps intended for a more mature audience, and the impact that that's having on a developing youth. But also as an opportunity is the technology that has allowed us to provide, for example, telemedicine to people to families that are in rural areas that would not otherwise be able to come to Tumwater or to Olympia. There is also some challenges that were identified that I was asked to share with today is the political environment and how that's impacting our youth and feelings of hopelessness and kind of draining their resilience, especially for those youth that don't have the ability to vote at this time. And so, for example, there's recently, it was communicated that there's going to be a law that's going to identify gender and how that impacts the youth that we serve in Thurston County, and how it's taxing on them and creates hopelessness for people who feel like they don't have a voice. But then also technology provides that opportunity for them to voice themselves. For example, the Me Too movement, allowing people who would otherwise feel like they're voiceless to voice that opinion. So technology creating both an opportunity and a challenge.
Okay, thank you. I'll swing back around to Leslie. Same question, challenges and opportunities.
Well, I'll start with the opportunity. Because we have mental health in all of our schools, we have the opportunity to provide a proactive training to families and children in our school district. We have that opportunity, we have the people. What is our challenge is that it is difficult to do when you have so much crisis to be proactive. And our mental health providers have between 2 and 5 schools and large caseloads, and then crisis also comes up. Consequently, it makes it difficult to do the proactive stuff that we really want to be doing. And really the reason we wanted them so much in the schools, to start with the things you're talking about and being able to allow kids to have conversations about the things that are bothering them in the community, in the public, and in their own individual lives. But when you are dealing with crisis every day, that's hard to get to. So that is something that I think is important as we reach out with our community partners to be able to move some of the crisis to another location. We might be able to get to that proactive place. That's our challenge.
Thank you. Ms. Smith, same question.
So I think the opportunity, and especially what I'm hearing from all the panelists, we all talk about collaboration, and I mean that professionally, collaboration is kind of the name of the game. We really look to rely on our community partners to help deal with some of the challenges that we all face. And in the emergency room, what we experience specifically is being able to refer someone after we kind of mitigate the current crisis to appropriate and accessible services. And oftentimes there's an overwhelming number of patients, and the services, while it may be available, like such as medication management, an appointment could be months out, and that doesn't help mitigate the exacerbation of mental health symptoms from the emergency department. And so we're trying to get creative with all our community partners as best we can. But then it comes down to getting families to engage as a whole. So if you have a youth that's willing to engage, if you don't have the parental support that is also engaging, or the guardian that's engaging, it becomes almost like a futile effort, because youth, as we've experienced, don't often have discernment yet. They don't have the ability to fully decide and get the support on their own. And if they do, then we run into the potential lack of availability or lack of funding for specific services that could be beneficial for that youth, whether that's because of insurance, not being able to get authorization because that's not within our power, even though we've assessed that need. And then, having with community resources such as developmental disabilities, child protective services, they have limited resources, and so everybody's looking at, okay, where do we go from here, especially if there's a placement concern. So from the emergency center standpoint, and even from the substance abuse standpoint, accessibility, engagement with families as a whole, and then just overall availability.
Okay, thank you. Ms. Shook, same question.
I want to echo a lot of the challenges that other people have brought up. I think that one thing that we see when we see youth in crisis is they are identified in that moment as having a crisis, having some challenges, having some safety concerns perhaps. But those safety concerns and those challenges seldom occur in a vacuum, and sometimes it can be difficult to put together a holistic family-based plan to provide treatment and provide the safety and security that youth needs. So I think that that's also an opportunity that I have seen in this place and this time. Currently in Thurston County, I see more subacute resources and more family-based resources than I think I've ever seen before working in crisis. So there's definitely a lot of work and a lot of support being put into place to manage that challenge that I think is just kind of ongoing. It's sort of the nature of working with youth and families. I want to echo another challenge that we experience in crisis is coordinating treatment and safe, less restrictive options for kiddos who are involved in the foster care system, and also youth who have co-occurring intellectual disability. It can be very difficult to access the mental health resources that they need. Getting those systems to talk to one another and coordinate with one another has been an ongoing challenge for the crisis system.
Thank you. Okay, we're now moving on to question number 3, and I'm going to start at the other end of the table now. Leslie, this question will start with you. What are your next steps as an organization for achieving your mission?
Well, the North Thurston Public Schools is working very hard this year to make sure every adult in the school district starts with a trauma lens, that they become informed about trauma and the behaviors that they will see with students who've been in trauma, and that they are knowledgeable about the things that they can do. Number one of which is to be a protective factor by creating a strong relationship with the child and possibly with the family if the family will engage. They also are working very hard on our district is working very hard on student voice, and this creates a very positive climate for our students, with our staff, and with those in the community. In addition, we are working every day to create a positive school climate and have a lot of work that we are doing, including surveys with family and staff around how to do that, and we're getting better and better. Next year, we are also coming out with a pre-K through 5 curriculum for social emotional learning. We're building time in the school day in elementary school that every student will actually learn social skills, how to regulate emotion, and how basically the CASEL standards and our new, hopefully, benchmarks in SEL that are coming out in Washington State. This is a critical part to creating a child that can re-regulate, have protective factors, and be ready to move on.
Thank you. Building resilient learners, right?
Right.
It's in our strategic plan. Ms. Smith, same question for you.
Sure.
What are your next steps?
Sure. So with our chemical dependency clinic, there, the goal is to continue to use the 7 challenges to kind of meet youth and adolescents where they are, like where they're at with their mental health and substance use, to try to promote a safe and trusting environment to optimally support kind of youth overall while accessing those services. And we are looking to educate the community about our psychiatric emergency services and what our limitations are within the emergency department, and really trying to boost those connections with our community partners so that we can ensure that families as well as youth are being referred appropriately, and that there's a good understanding of what we are able to provide. And we're always working to retain and keep dedicated clinicians in the emergency department, as well as chemical dependency, to help the overall community and promote Providence mission and values, to really know the patient, care for the patient, and kind of ease their way overall. So
Excellent. Thank you. Ms. Shook, same question.
So we are, as an agency, we are continuing to work towards our goal of improving our ability to do assessments and outreach in the community to assess youth where they're at, where the crisis is occurring, to keep them out of the emergency room at the hospital unless they really do need to go and see Eliza. We would like to be able to handle that in a less restrictive, less traumatic environment. To the end of staff training and development, a number of my staff are currently pursuing their education as chemical dependency professionals. With the recent changes in the law that allow for involuntary hospitalization due to substance use disorder in the same way that we can provide involuntary hospitalization due to mental health disorder, we are seeking to improve our skills in assessment and intervention regarding substance use.
Excellent, thank you. Ms. Willis, same question.
I want to say ditto. Promote resiliency, promote hope, promote social competencies. The best way is to tell you a quick story, so I'll be really quick. In Safeway, where I do all my parenting research, I saw a father who was really struggling, and he had a 2-year-old-ish infant who was screaming and crying, and his face was red, and I wondered how he's going to make it through the store. Is he going to make it, or is he going to bail it and go home? And I started stalking him through the store. So he goes to the produce aisle, which is the first place, and the child kicks out screaming and knocks over bananas, and the dad goes, "It's okay, Mikey, it's okay, we're going to get through this." And he picks up the bananas and he keeps going. Mikey's not impressed. He continues to scream, and dad goes to the next aisle, and I'm watching him to see what's going to happen. And the kid kicks out, Cheerio boxes go flying, and he goes, "It's okay, Mikey, we're going to get through this." And he picks them up and he keeps going. Now the kid's still screaming, but dad gets smarter, and he goes down the middle of the aisle, and he doesn't get near the edges at all, but he goes to the store every aisle at a time. I'm almost done. And we get to the checkout aisle together because I was following him through the whole store, and now Mikey's calm, and I say to the dad, "Congratulations, you made it, good job." And he looks at me and he laughs and he goes, "My name's Mikey, this is Timmy." Through the whole story, he's talking to himself, and I just thought that was hopeful thinking, right? Because in my mind, I would be thinking other thoughts, not so negative, kind of a victim of my situation. He wasn't. He was thinking about how to navigate. We want all parents, all kids to know they can navigate. They're resilient.
Excellent, thank you. Ms. Faris.
I don't have such an exciting story. Shelly's awesome. So as far as next steps, we are starting a supported employment program, which will help those that are struggling with behavioral health challenges to be successful in engaging in employment. We're hoping to continue and expand our reunification services, which is helping youth that are at risk or currently homeless to reunify with potential family members. Eventually, hopefully in the near future, we're hoping to be able to see all youth and not just youth on Medicaid. We have a few non-Medicaid slots, but just not near enough. And there's a lot of uninsured and underinsured. So we're going to start taking commercial insurance, private insurance, and looking for gap grants. And then last but not least is the physical health piece, because a lot of the youth that we refer to physical health, they're not getting their medical needs met because they're not going. So we recognize that eventually we're going to have to bring those services internal, but we want to improve the collaboration with our existing PCPs for those that have them.
Excellent, thank you. Mr. Maldonado.
At CMAR, as a community-based organization, we're committed to growing and evolving in this dynamic process that's mental health. We plan on expanding our collaborative care, and we have a few memorandums of agreement. We've signed some agreements with local pediatricians in Thurston County, and we've committed to accepting referrals for mental health and working in collaboration with primary care settings outside of CMAR. We are committed in developing skilled clinicians, child mental health specialists that are capable of managing least restrictive alternatives, keeping families in their community. And we plan on doing this, again, as our community grows and as the needs change. We're committed to changing with them and being able to meet the need.
Excellent, thank you. And I want to thank you all for being here and helping our North Thurston community be aware of all of the resources. finding the right resource, understanding how to access it, understanding the privacy laws associated with teen health care can be very challenging. So we really appreciate your expertise and your time tonight. And I'm now going to turn it over to Gretchen Maliska, another North Thurston Public School Board member who will take over.
I have to say this is one of my most favorite times. We started this program last spring with early years learning, and it was a real experience for us to collaborate with our community, to hear from you what questions were still unanswered, to make an opportunity for us as school board members to create our youth to be their best selves. So thanks for being here tonight. And now we're going to ask you to do a turn and talk session. So inside of your information, you have 3 cards. And we're going to ask you to work with your neighbors, or you're welcome to work by yourself, but if you want to collaborate with your neighbors, that would be wonderful. You have 3 cards. What have you learned about the support structures for emotional and behavioral health for youth? What questions do you have about emotional and behavioral health of our youth? And this one we're going to ask you to turn back in right away because we're going to use that to facilitate the remainder of our meeting. And the last card is, what suggestions do you have to strengthen support for emotional and behavioral health for our youth? So if you want to take just a few moments and work through those cards, we'll be walking around the room and collecting those from you shortly. Thank you.
Okay, so the way it's going to work, I'm going to ask you guys a question, the panel. These are directly from the audience, and then we'll actually have anybody that would like to answer first, put your hand up or something, and we'll go from there. So we have a bunch of great questions here tonight, so I hope you guys are ready. We'll start off with the first one. It says, what are the gaps in the community that make it hard to achieve your mission? So you all talked a little bit about a mission, so how can we fulfill those gaps?
I'll go. I always have something to say. So I think one of them is there's a lack of awareness about trauma-informed strategies and cultural competent strategies. I think we could do better informing leaders in our community, adults who influence kids about those things. And there are some gaps in our service system where kids are falling through, especially kids who have duodiagnosis or who have there's a gap between those who have trauma and those who have complex trauma.
Okay. Anybody else?
I also think that one of the things that our mental health are doing is serving in a gap. Both parents who have no insurance and parents who have insurance with large deductibles who cannot afford to go to mental health, they're serving those students, but in addition, they're serving students who are afraid to go to mental health because they're undocumented. They're fleeing domestic violence. In some way, they can't get their name in the records. And so those are the kids who are in this bubble that we are unable to find resources for, and those are the kids we end up serving most.
I'm going to go back to one more. Poverty impacts our youth and our families' ability to access services. Domestic violence services is a classic example. If you are a low-income male, it would be very difficult for you to find services to help you address that. So our community just has poverty is an issue.
Awesome. Thank you. We're going to move on to the next question. What are we doing to utilize technology, Mr. Maldonado, you brought this up earlier, and social media as a framework for teaching youth about mental health and self-care? How can we use these tools to benefit students?
Specifically in the emergency center, I know I've specifically used Teen Link. It's a huge resource that has availability for parents and youth. We can use. Am I not speaking? Oh, excuse me. So, and we use Teen Link it provides education for parents. It provides a forum for teens to be able to chat with a peer counselor. So we try and utilize peer support when we have those options. So and it allows them to kind of use social media to get education about what they may or may not be going through, and also for the parents. And then we also, when we can, we consult often with Catholic Community Services or community youth services about apps that address self-care. So if there's a team specifically focused on apps, then we recommend specific apps that could help promote self-care and mitigate self-injurious behavior, and then help educate the parents on why that could be a beneficial use of their time. So we do try and turn social media as a positive when we can, and help create some of that discernment.
And we have the opportunity to use social media for outreach. Unfortunately, because of confidentiality, there's a limit to what we can do. And we have to be very careful with email and communicating in insecure networks. But one of the greatest opportunities that we've identified is the opportunity to do telemedicine and allow a family who perhaps has a challenge with transportation to go to their primary care and have a consultation with a psychiatrist. And we've been able to do that as far out as Vancouver, out in Aberdeen, and it's proven to be a wonderful resource for the families.
I think that social media also helps facilitate peer support and the recovery that can go along with peer support, which is really powerful for someone of any age, but particularly for youth and adolescents. So I think it can be sort of a fine line when that can become harmful or possibly a problem, but I think that there's a tremendous resource there in terms of facilitating peer support.
A couple things, just recognizing that people are texting more often and they're using apps, and the behavioral health field is kind of slow to transition into some of that, but one thing, we know that youth reach out using text, so we started using texts as a way for youth to set up appointments and to be able to cancel appointments, to reach out and say that they need, a sooner interaction with their therapist. But there's also a national crisis line now for youth to text to. I think it's 741-741. But it allows youth to reach out in a way that may feel more comfortable to them. And there's also some apps for families. A recent one that's being researched, a pilot project that we're doing, is called iConnect, and it's available to all youth, not just CYS, that are involved in behavioral health that have disruptive behaviors. And using an evidence-based approach called contingency management, it allows there to be like a reward system that's set up for the behavior that's wanted instead of that disruptive behavior, and the youth can see how many points they've got, and the parents can manage those rewards, whether that's more time with mom or the pair of shoes they want or whatever it may be. So there's a lot of great technological opportunities right now.
Awesome. I love the idea about texting because, I have kids and they don't even talk to each other. They text each other. So texting is a huge way to get to them. So great idea. The next question is, we've had, this question came up multiple times, and it talked about the students and the parents. And the question is, do the students and parents know where to get the information to seek help? And who can they reach out to besides the counselor? And I don't think a lot of the question came up multiple times, so I'm not sure they know exactly where they can go as far as the students and the parents are concerned.
Well, all of our counselors, in fact, we have a yearly meeting for mental health providers in our community to come in and talk with all the counselors. And so all of the counselors are well versed and have a list of possible providers, and they have them by what their strength is and what insurance they take and what their specialty is and what organization they belong with. And so our counselors are the first line for kids and parents to seek help in our district, but they also have the ability to refer to the mental health provider in their school who has even more in-depth knowledge of how to get the right corresponding needs met.
There's also, for Thurston County specifically, there's a website that a behavioral health organization helped create, which is called The Hub. And that is a place where all of us as providers can go in and enter our information, and youth and families can go there and enter into the search bar what they're looking for, and it's got a lot of filters that can help decide kind of which might be the best numbers to call, because sometimes it's that there's so much information in so many different places you can go that it's a little overwhelming. So there's a Facebook page, the Thurston Masons Systems of Care page has that link there, and I believe the Behavioral Health Organization for Thurston Mason has it as well.
Awesome. Next up we have, what are some ways your organizations are supporting the LGBTQ plus youth, competency training, workshops, seminars, etc.? Do you have any specific point people at your organizations to advocate and support the LGBTQ plus youth?
We do, and we provide parenting classes for parents who are raising a child who may be gender questioning, and have resources. At FEST, we call it FEST, Find Yes at FEST, so people don't have to, we may not have the answer, but we will help parents find the answer in the community.
With Providence, we do set up trainings, and we bring in outside organizations who specifically specialize to come and train and offer it to actually our whole hospital staff, not just our mental health services. So we try and get those resources and those trainings when we can.
And at CMAR, we've actually included the LGBTQ as part of our cultural competence for our providers, mental health professionals, and we have made it a point to create a safe environment for all people to come and receive the services that they need in a welcoming and a safe environment. And it's going to be an ongoing training on a quarterly basis. Unfortunately, there's a certain amount of turnover in community healthcare, so we want to make sure that everybody is aware of our culture and our environment that we're trying to create.
All of our staff at North Thurston have mandated training around this issue of gender equality. And in addition to that, we have in our schools several organizations and clubs around, from the Gay Straight Alliance to Pizza Clutch and Stonewall and a bunch of different organizations. And we have a director of equity that is involved in making sure that equity in all ways is considered at all of our schools and all the work we do.
Awesome. Thank you. Next question. How would you rate the peer-to-peer approach for youth as a best practice?
So I can say at CYS we have certified peer counselors, and those are people that are now adults, but as youth had experienced mental health challenges or behavioral health challenges, and become certified to be able to be a peer counselor. It's a certification through the state, and then they get a lot of training to be able to share their story of recovery, be able to be a model and a mentor, and also be able to model that transition, successful transition to adulthood. So that's the primary way that we use peers, but we've also started using them in other ways, like for example around sex trafficking, and it really does change the dynamic to be interacting with a peer counselor as opposed to a professional. It just takes it to a different level. They can do a lot of great outreach and engagement with our youth.
Very nice. Next question. What does collaboration look like between the members of this panel? I mean, do you guys interact a lot? Do you guys go to a lot of seminars, or how does that handle? How does that happen?
We do a lot of collaboration with our DCRs, with Providence, with CYS. There's also other behavioral health community partners that are not here, but we collaborate with all the time, BHR, Northwest Resources. There isn't any one of us that is as good as all of us. And in community healthcare, I think a lot of times we have to rely on each other to fill those gaps that we've identified this evening.
And I know that the school district is working, our mental health professionals are working at this. I've probably spoken to each one of these people in the last 2 weeks around difficulties or challenges around getting a child into the right services. One of our people have called them. We can't, school districts just cannot do it alone. It absolutely requires the collaboration of all in the community.
I want to say the teachers, my daughter-in-law is one of them, in this district are really good at reaching into the community for experts when needed. I know I've been invited to IEP meetings. I've seen school teachers at CPS FTDM meetings. The school's not just in the structure, it's also in the community, and they're great collaborators.
For the DCRs on the crisis team, we collaborate with a lot of the different entities and providers in the community because if we end up seeing their clients, we want to work with those case managers and those professionals because they know their clients the best, and they can help us create a seamless plan to make a plan for safety. In particular, Eliza and I work together very closely. My DCRs spend a lot of time in the ER, working with clients there, and so we work on discharge plans. We work on working through whatever blocks are in place. I've worked with Alicia at times on taking care of clients that we have in common as well.
Our goal, I think, overall is to implement like the most effective, least restrictive alternative to someone needing to go to an inpatient level of care. We consider that, I think, generally as the highest level of care. And so taking that into consideration, the way that we can do that in our varying levels is to reach out and ask, what options do you have that I haven't thought of? What other options are there besides this that could help meet the needs specifically for crisis? It's for health and safety. I mean, that's our primary goal. And then how do we sustain that within the community and at home? And that's when we couldn't do that from the emergency center without community collaboration. And so having, the mental health specialist team, they've been like, as I mentioned earlier, they've come to our staff meetings with my team before. The DCR team, same thing, CYS, Catholic Community Services, CCS. So we really rely on each other to help get those services and those connections.
Just to add one more thing, there is an opportunity for you guys to engage in that collaboration, and that's through the Thurston Mason Systems of Care Partnership. It's a monthly, is it monthly? Monthly meeting where all the providers are at the table, as well as the systems. So the school systems are there, the juvenile justice systems are there. It's not Children's Administration, DCYF, all the changing acronyms. But the point being is that the full system is there to talk about where are the gaps, where are the needs, where are the opportunities for us to collaborate together and really meet the needs that our community has and the needs of youth and families. So families can speak at that table, youth can speak at that table. It's a tri-led process, which the state has recognized as one of the best, one of the standards in the state for that.
Awesome. This next question, I want to start this question out by saying the question basically is, how large is this problem? We think it's a huge problem. Obviously, that's why we're having this meeting tonight, this community talk. But somebody's asking specifically, what percentage of students do you think are hampered by this problem, or has this problem, or is looking at this problem down the line?
80% of children in relative care are there due to parental addiction. I think it's a pretty big problem.
So as far as, it's not this year's statistic, but a recent statistic for youth between the ages of 13 and 18 that are experiencing some level of mental health or addiction challenge was 22%.
Just homelessness, in every single classroom in Washington, there's a homeless child. That's the data from last year.
Wow, very humbling, obviously. The next thing is, because it's such a huge problem, and we're having more and more, support groups and things happening in the community. What do you think the average amount of time it takes to get a person that's going through crisis help, or how can we shorten that or get it faster help?
I think that varies. It really depends on kind of what's going on. there is a triage process that we use, and we give priority to, for example, folks coming out of a residential setting and they're under an LRA or an LRO. I mean, those are folks that we want to make sure that we can wrap our arms around. But we don't want to neglect anybody else. So it really honestly just depends. I think we at CMAR, we make it a point to, if somebody comes in, from the time that they come in and request services, we want to get them in within 5 days for an assessment. And we're going to do everything we can to get them in, if necessary, within 30 days for a psychiatric evaluation. And again, that's really going to depend. I mean, I don't want that to be, black and white. It really depends on the need and the time and kind of what's going on with the client that's requesting the services. But generally speaking, we can get somebody in within a week. If there's medication management that's involved, no later than about 30 days, 30 calendar days.
For us, waiting lists kill people. We try really hard not to have them, but they are in our community. And I know we spend a lot of time, energy, and money on a small population that just takes a whole bunch of our resources. And I would love to see us invest in kids and put more time, effort, and resources into prevention so we don't have the need for the intervention.
I'll just say that every day counselors are sitting down with kids all throughout the day who are in crisis. And our mental health people are getting those kids daily. They are the stopgap right now when sometimes they're trying to get into a program that can take months to get into. The mental health person at the school, the counselor at the school, they're meeting with those kids sometimes daily, sometimes several times a day. Sometimes the kid has a universal pass to just come whenever they need to the counseling center. And that kind of stopgap measure is really tough on the system because there's a lot of other work that has to be done by counselors and regular clients to see in mental health. And so it's very hard because there is a waiting period for most programs that they get into.
Wow. Okay, I'm going to switch your thinking a little bit with this next question. It says, what are the critical factors that lead to mentally healthy youth, and how can we recreate this experience for the at-risk students?
I think we can all agree, right? Strength-based, community supportive, peer supportive. What we want to do is we want to improve self-image. That's going to increase the youth's resilience, and the more resilient people are, I think the less impact a crisis or a change will have. It really is going to take a village, though, and increasing resources and access to those resources in each community, I think, is the goal of everybody that's up here.
The evidence-based practices, Dr. Ken Ginsberg is probably, his 7 C's are probably the most evidence-based thing around building resiliency in youth. And that is our method in our district to use. But that starts with having a personal relationship with every child in every class. That is the deep, deep work we have to do in our schools and in our homes and in our community, is that we have to work to know every kid by name and by strength so that we can pull them up, because it is one person that makes a difference in a kid's life.
And I want to dovetail on that, because kids learn about resilience first by example and then by having somebody believe in them and guide them through it. Mentoring, if you want to contribute, other than go to our auctions and our breakfasts, it is mentor a kid, be a positive role model for a kid.
There's a resource that we use in terms of training our staff that I definitely would recommend to absolutely anybody, whether you're a family member, a community member, or a professional, and that's the Searched Institute. They have done large-scale studies, international studies that have shown what makes some youth bounce or resilient and others not, and it lists those assets. They're called developmental assets, and there's 50 of them. some internal, some external, and it gives really concrete examples on how to build those in youth.
Awesome. All right, so this next question is simple but complex. How do you help kids with depression and anxiety?
Well, at the point that I contact them, they are in a immediate crisis, and we protect them by assessing their needs and their risk and making very specific, concrete, in-the-moment decisions about what they need. And sometimes it's not what they want, but it's what they need. So holding that responsibility around keeping people's physical safety foremost is how we do that.
In the emergency center, we often do the same thing that Jessica has talked about, and we also aim to educate. So we hear symptoms, and we hear maybe someone saying I'm depressed, and we help to explore what that really means to them, and have that be like a place to discuss self-empowerment and self-understanding within the emergency center, and how it's affecting a crisis and how that affects overall well-being. And specifically within the chemical dependency, or the services that we can offer for substance use, using the 7 challenges is a way that we really focus on that, and how those symptoms or what's going on impacts their use, or when they choose not to use or don't use. And so those things, I think, really go hand in hand with what we try and do, the emergency center and outpatient.
I was hoping you'd ask. I brought a list. Pro-social activities, sports, art, music, faith-based clubs, service learning, get kids moving. The second one's pro-social peers. What friend group is that kid hanging out with, and are those friends making things better or worse? What can we do to promote strong peer groups? And the third, pro-social adults. Coaches, teachers, faith-based mentors, friends. What can we do to enhance our community around mentors?
I'm going to embarrass Mr. Maldonado because he did exactly what every adult needs to do. His kids came in and he hugged them. That's what needs to happen every single day with every single kid that you have in your purview, is you need to put your arms around them physically or intellectually or emotionally and say, I care about you, I care about who you are, and I want you to be part of my tribe. I want you to be part of this, whatever this is. There's nothing more powerful than saying to a child, I've been watching you, I see how great you are, and I want you to be included in what I'm doing. And that is just the key to prevent depression and anxiety.
Well said, Leslie.
You didn't embarrass me. You may have embarrassed my son, Henry Maldonado, a senior at North Thurston.
He is about 3 shades of red right now. He's, oh, man. Do you guys have anything to add?
Again, difficult to top, but so as far as our primary outpatient services, we see a lot of the depression and the anxiety there. Again, we focus on that underserved population of adolescents and young adults, those that often are falling through the cracks. They're either not engaging in services, or they're not getting the same outcomes as services for children or services for adults. So we use a youth-driven, family-guided approach. We meet them in the home and community. We do wraparound services. We provide whole person care, but it's very much focused on engaging that population. We can't help them in terms of treatment or connection to resources or building up their pro-social aspects of their life if they're not engaging in services. And one of the components of that is stigma. That's one of the reasons that we have peers in our services, not just for the youth, but also for the caregivers. But in addition to that, there's some community efforts that can be really helpful. One is the youth mental health first aid. Those classes are available to the community, and it's something that True North is doing a great job with, ESD 113 through Project Aware. But it's something that's taking place and being supported at a federal level as a way that we can influence that stigma and also help navigate those kids to treatment.
Do you want to say something?
Here in this district, November 7th and 8th, we'll be holding that for our staff.
Nice. Ms. Maldonado.
And just really quick, we have a client-centered, strength-based treatment plan that we do with all of our clients, and we empower them to take charge of their life. They are the experts in their life. They understand what better looks like, and we try and be a facilitator to get to that point. And I think allowing them to take an active role in what improvement looks like in their life is critical to achieving those goals.
Awesome. So that concludes this portion of our session tonight. So thank you for the wonderful questions. I'm going to turn it over to Chuck Nammon. He's going to get some closing remarks.
Thank you very much. You know, the whole concept of emotional behavioral health in youth and also building resilient learners is really a key important point that this board, the staff, and you as a community and also panelists have in common. I've been on the board for a while, so I'm going to give you 2 points of conclusion with regards to what this board is trying to do. Early on, we used to be known as North Thurston School District. And the board had a real interest in that because there were a lot of school districts, but we wanted to be something more. So the board had a discussion about changing its name. We are now the North Thurston Public Schools. The idea is that we belong to you, and your schools are your vehicle for affecting the learning of children. And so that's an important element. So the board actually changed that name for a purpose. Another thing that we do a lot of, and that is take a look at policies. In fact, if you were to look at our larger policies, we have a series called 3000, which is a very lengthy policy, and it deals with students. It deals with their welfare, it deals with their health, it deals with their safety. And in a very real manner, it also deals with the kinds of abuse and neglect that we find students have. An important part of this also are what are called homeless kids. Leslie mentioned homeless kids. Homeless kids, interestingly enough, and we have them in our district here, they do not have places to live. Many times they live in cars or in public places. So it's important for us, obviously, to be able to have resources. And I'm going to just acknowledge this panel is a resource. In a very real manner, it's a community resource, and it's really a strength that we have. Now here's the second part that this board has decided to commit to. We are moving in an area called policy governance, in which we're going to have these community discussions. In fact, this is the second one. These will continue next year also. The whole concept behind this is the board wants to listen to you, wants to involve resources and panelists, and so that's an important element. Now let me just say that they not only give you a lot of information, but they also give you resources that you can point to. In fact, this is one of the books that was brought for our attention to look at. Now, what is next? The next step is this. We're going to take your suggestions and your elements that you have given us, and we're going to take that back as a board. And so on November 27th board meeting, we're going to talk about or talk around the whole idea of resilience. And the things that you're suggesting, we're going to take back and we're going to do something with it in terms of action. So what I'd like to do is I'd like to say this, that whenever we have a meeting like this, we really love the fact that the community, the parents, panelists are all here. And a successful meeting is this. You start on time and you finish early. So I'm going to let you go a few minutes early. I want you to give yourself a round of applause. So let's begin. We're dismissed.